First of all, I would like to thank my guests here for this unique opportunity of having this, of comparing several countries that are struggling with the same issue, with the burden of the Hep C. And I strongly believe that this is a unique opportunity of having together the most important leaders. I will start with Professor Stranu-Cercel, that everybody knows that he's the most experienced and most important. The most important leaders in the area. Spain, France, UK and Romania. Of course, yeah. So since this issue of Hep C is not only affecting us, many countries have passed through the same stage of evolution in terms of taking care of public health problems like Hep C. So in terms of if we want to have a look at what have been done so far in the Romanian healthcare system, considering the dynamics and the evolution of technology in the healthcare, it is important to realize that we don't have to struggle too much in coming up with really creative and innovative solutions in terms of health policies. We just have to look abroad to see what other people have done already, because most of the countries have already been where we are at the moment. We can, in terms of evolution of the Romanian healthcare system, we can look at the general practitioners' introduction in the years of 2000, that was inspired from the UK healthcare system. We have also several measures that were taken from the French healthcare system. So basically, I strongly believe that this is what we should do now. We should broaden the scope of discussion, broaden the dimension of this problem, and look what other people are doing, so we might find the best solution given the Romanian particularities. I will start by inviting Professor Stranu-Cercel to highlight the main priorities following our previous panel and yesterday's discussions, and then I would like to move over to my other guests to realize the importance and how other countries and leaders and policymakers manage already to find a solution for effective solutions for this important problem that affects all of us. So, Professor Stranu-Cercel, I will invite you to start with the highlights.
Thank you, Andrei. For me, the problem is extremely simple. We have to do something more. And for this, I think that we have to involve also the general practitioner in this issue. And as we discussed yesterday and during this morning, the general practitioner is supposed to be the main leader for the F0, F1, and maybe F2. What that means? That means for the infections with low degree of activities, the general practitioner can deal without any problems because we do not estimate to have any complication. For the patients with high level of fibrosis, that means F3, F4, mainly cirrhotic, non-complicated and complicated, this is supposed to be in the hands of the specialist. That means infectious disease specialist and gastroenterologist or hepatologist. From this point of view, I think that things are really clear. How we do this? First of all, we have to put in place a training system for the GP. We have to inform the GP what they have to do, how to check for DDI, drug-drug interactions, because the majority of the patient has a lot of other diseases, comorbidities. They took a lot of medication. This kind of medication may interfere with the medication for the Hep C. So in this context, they have to be absolutely aware what they have to do and to check on the Liverpool side, to put all the medication that the patient has, and to check for the contraindication of the medication. This is a very important issue. So if we put this on the puzzle, I think that the success is there, and we just have to push the hand and pick up.
Thank you so much. I would like to also to focus on several aspects, several dimensions. I would like to focus also on the social dimension, on the health economics, of course, it's really important to focus also on the regulatory system, and then, of course, we need to have a patient-centered approach. So I will pass on to our colleague, our guest, Andy Steintorp. You have a presentation, right?
I do. Basically it's the report from the Public Health England about the approach that's been taken in the UK to address Hep C. So I'm going to do the professorial thing as well. I'm going to wander over here and speak to my slides, if that's okay. So this is an official report. It's not my summary, but the use of this, if I remember to switch it on, is that it gives you an illustration of what has been done, what the targets are, and it illustrates that there's an element of joined up thinking in terms of the way the UK is addressing the issue of Hep C. It's a relatively small issue in the UK. We have only got, where's the numbers? We've only got about 214,000 people estimated. That gives you a percentage in, fewer than 1%, about 0.3. It's probably an underestimate, but we've still got a significant issue in the UK. And as such, we've taken on board the World Health Organization directions to try and put in place a strategy to use the new therapies to reduce the burden. And we've put targets in. So there's a target up here to reduce the HVC mortality by 10%. In the advent of the new technologies, we've actually made a significant step in that direction, and in 2015, the rate of mortality fell by 11%. So the technology works. It's just a question of being able to A, afford it, and B, directing it to the right people. So the other targets are reducing new chronic infections by 30% by 2020. We do have more ambitious targets as well. So by 2030, those targets increase significantly. I could go through the rest of the slides, but I don't particularly want to bore you with them all. So we're looking at increasing the number of people we're treating with the new technologies, and it's, oops, sorry, I pressed the wrong button. And it's the aim is to increase the number to address the burden of disease. So it was a 40% target in 2015, so that's now gone up from 6,000 to just short of 10,000 in 15, and the aim is to make that number go higher. There is an awareness issue as well, so it's an education, and I think that's a fundamental part of the strategy to improve the awareness. And in this context, the major burden in the UK is what's called PWID, which is people who inject drugs. So they're our major cause of the spread of hepatitis C in the UK. And so we've got a target of improving the education of both the status and of the disease within that community. And so it's known that only half of the people who inject drugs know their status. And as part of that program as well, it's also about providing sterile needles and safe ways to feed that habit, I'm afraid. But there's other education programs around trying to sort of lower the habit of IV drug use. So I won't go through any of the rest of that. I'll leave that. But in that context, I think there are some messages there for Romania in terms of building a strategy that joins up all the components of government, education, to try and increase the awareness. As my colleague here said, it's about improving the way GPs identify and treat people who might have the disease, and it's about gaining access to new the new technologies to treat people who've got the disease with a view to eliminating it. The World Health Organization has set standards for countries to try and eradicate Hep C, and I think it's incumbent upon governments and administrations to work towards that. So without further ado, I think I'll hand you back to Andre and pass you on to colleagues from other parts of Europe who've got slightly different perspectives on HPC.
Thank you so much, Andy. Thank you so much. I will move over to our guest from France, and well, France just was really ambitious in terms of approaching and treating and getting a control over the Hep C situation in France, right? So from what I know, starting with September 2016, you already started some kind of open access, if you want, treatment for patients. So everybody who has the disease and has the virus, and the virus has affected somehow the organism, it can access treatment, curative treatment immediately. I would, since it's one of the biggest countries in Europe, I can imagine that was a struggle to find the right solution and to have everybody on board and finally to be successful on your action. So I would like to invite you to share with us the most important steps and challenges that you have encountered so far in your dealing with this issue.
Well, thank you very much. First of all, I would, sorry, I have a broken voice, so for the translators in particular, it won't be perhaps very easy, but I'll do my best. Well, first of all, I would like to underline what has been already said, and which makes the situation quite unique in terms of public health question at the 21st century. We have to deal with a disease of epidemic scale. This is the first point. The second point, we have other diseases of epidemic scale. We have every winter flu epidemic, but this disease has an important impact in terms of health of patients in the population, with an impact which could be the death ultimately, and before the death, very serious consequences in terms of liver insufficiency and other complications. So this is the first point on which we have to answer, to find reasonable answers. The second point is the original situation where the majority of the patients ignore their disease. Even if the risks are high, they are ignoring the disease. And that has its own importance in the way to deal with the situation. And the third point, which is important to consider in dealing with this situation, is that we have, first of all, diagnosis tools available. But the question can be raised concerning the accessibility and which tool to use in an efficient way. But besides the diagnosis tools, we have also treatments which have recently evolved. And we're coming from an era of long treatments associated with a partial response and a lot of adverse events. And now, since the availability or the development and the results of clinical trials for direct acting antivirals acting on the virus of hepatitis C, we have very efficient drugs which could allow to envisage eradication of the disease, cure of the patients, with higher convenience of use, not only the fact that it's a shorter treatment, but also better tolerated in terms of adverse events. It's also more or easier to manage with co-treatments in terms of interactions. Other aspects of the new treatments are related to the level of resistance, or the risk of development of resistance, which is lower. So there are many progresses which are offered with the new treatments, which bring this issue of treatment is quite easy in scientific terms. These are the treatments to apply. But then there are plenty of questions related to access to this treatment and the cost and the resource to manage. So if we go back to these 3 points, in France we have a quite high number of patients. The prevalence is estimated to be around 300,000 patients. The proportion of patients who have been diagnosed correspond to a little bit less than half of them. And these patients are of variable stages. Obviously, those who are, present already complications are well known, and for the others, things have changed in a way that since very recently, as you said, there has been, first of all, a scientific evaluation and then a political position establishing the fact that all patients must be treated. Again, in compliance with the WHO objective and objective of eradication of the disease. So to try to treat even the asymptomatic patients infected. So to do that, first of all, concerning the epidemic scale of the disease, in France, we had already a lot of campaigns to increase the awareness of similar diseases on similar populations at risk, in particular concerning HIV. There was no recent campaign to increase more the awareness of the disease, probably because the information was already quite well known, in particular from the health professionals population. An effort has been done in order to comply with good practices. So it's not only the information to the population at risk or population by large, but it's also to make available to the health professionals guidelines in order to comply with the best practices according to the best. By practices, I mean diagnosis and treatment practices. So this is under the term awareness. It's awareness of the population exposed, awareness of the population at risk of the infection, but it's also awareness of the health professionals who must professionally know the disease and how to deal with it. Concerning the diagnosis tools, we are fortunate enough to have a good coverage of the territory in terms of labs and in terms of reimbursement of the tests. The question in terms of costs is more important and more difficult concerning the treatments because according to the number of patients, if we multiply with the current price of the product, it represents an important burden to the national health funds. And then it's less scientific. It's more how to negotiate and find compromise between the different costs of the different diseases for the population in general, for the population at risk, and concerning the compromise with all the partners, and in particular the pharmaceutical industry. And I think we will come back probably in more details concerning the price of these medicines and how to find solutions to deal with that. That would be my first comments on that for the French perspective.
Mm-hmm. Thank you so much. Thank you so much. I mean, I really believe that we should look really to notice all the details, because it's one of the countries with one of the highest population in Europe, and you've managed to have to cure and control, actually, to get a control over the dynamics of the disease. So this is important. It's not that many countries have achieved this so far. So thank you so much. I would like to pass over to our guest from Spain. I know that Spain also has already done some really important progresses. You have allocated an important amount of resources to try to cure and control this disease. So I would invite you to share with us, because it's also a success that we would like to have a closer look, maybe to see some similarities in terms of intervention that could apply to the particularities of the Romanian context.
Yeah. Okay, thank you again for the invitation to be here. For me, it's a real pleasure. As you probably know, Romania is the first country in Europe with a higher prevalence, and Spain is the second one. So I think we are playing in the same game. In this case, it's not good news. In order to provide some data, let me tell you that the prevalence in Spain is lower, it's around 1.5%, but the total population with hepatitis C is around 900,000. So it's a huge number of people in order to take in different measures. We have a national strategic plan. That is very good news. It was published last year, 2015, so we have a national strategic plan. The reason because we have a national strategic plan is not related to, it's mainly related to that we have a very good news, is that we have some treatment that can cure people. This is the reason because we are speaking here about hepatitis C, because it's not very often to speak about that some new treatment can cure people. The reason because we have in Spain a national strategic plan is because patients were going to the street say, okay, we want to have this new treatment because we want a cure. And also, of course, this is the issue that we need to discuss, is how to stop the dissemination of the disease. So what about this strategic plan? Several ideas. The first one is a national and regional strategic plan. So it's agreement with the national government and the regional government. In the case of Spain, it's very important because the real payer in Spain are not the national government, it's the regional government, it's the budget holder. This is the first important issue. The second one is we have right now a really official register of patients. So right now we know how many people are diagnosed and we know right now how many people are treated. Let me give you some number. Right now in Spain we are treated around 50,000 people every year. Yeah, it's a lot. But we need to go back. If you are thinking how can you pay 50,000, take into account that the official price a few years ago it was around 90,000 euros or dollar. The reason is because we got, at the same time that we was making the strategic plan, we was making a budget proposal to pharma companies. So we have like what we call price volume agreement. So when more people are treated, less money we pay. So we pay the full price at the beginning of the people. I mean, the 10,000 people at the beginning, we pay the full price, and there is discount if we treat more people. So right now, we have been treating only people with the severe grade of the disease, so only F4 and F3. It looks like that in the next following years, probably next year, we are start treating only people with F2, F1, and probably F0. So because the agreement with the pharma company had to be renegotiated and so on. The idea, I mean, in this sense, we are not looking for a national strategic plan for 2030, because we have a WHO proposal that the eradication of hepatitis C will be in 2030. So in this sense, we have a national plan, we have a register, we are an agreement with pharma companies. So the idea is we control very well how is the transmission of the disease. So we want to, right now, to give access to people as soon as possible. Yeah.
Thank you so much. Thank you so much, Jaime. I would try to get back to the initial segmentation of the problem. I believe, I mean, all over Europe and also in the North American states, there are several countries, or at least there is the hottest topic at the moment is communities with budgetary restrictions. How do we split the budget? How much it goes to prevention? How much it goes to treatment? Of course, the same questions for the actions and results of them. From my point of view, it's important also to try to analyze several different aspects. And we should start with where a patient that eventually is going to be diagnosed with Hep C, where does he find himself at the moment? So first thing we should look at, for instance, in the Romanian case, is the general awareness. So patient that eventually is going to be diagnosed with Hep C, what's his source of information is, and what are the sources available already, how reliable are the sources, how useful are the sources. Secondly, we should think about prevention, general prevention. Also early diagnosis, because this is important. Every chronic disease comes with higher costs as the disease advances. So this is also important to consider. Following prevention and early diagnosis, it's important to look at clinical management. There are some important particularities in Romania, given the fact that most of the patients are still treated in the tertiary healthcare system, in hospitals, given the fact that we lack an important part of doctors and professional caregivers in general that work in hospitals. So basically, we are struggling with another problem. That is that the doctors have much more patients that they can treat and take care of. So it's even lesser time to think about and act in terms of prevention and awareness. And of course, the last part would be the follow-up process, which should be also, I think also in the Romanian case, there is place for improvement. Most of the patients, or generally patients speaking, most of the time they have they have a baseline evolution. So from time to time, of course, you need to change the treatment and perform some tests and analysis. But most of the time is basically looking after some general indicators and then just follow up on procurement and make sure they stick with the treatment and make sure they are all right and know what they're doing. From this point of view, I would try to move back a bit to the Romanian situation, especially that we're, in terms of functionality, infrastructure, I know that Professor Străinu Cercel has been working a lot in the past years, not only building up the infrastructure according to the local needs, but also an important message is that we have already a register in place that could be functional, but it's not 100% functional. And I would try also to explore the causes of these issues with the registry, because if you focus on solving a problem, you need to have a clear needs assessment over that problem. Otherwise, for sure, you're going to miss some important elements, so you're not going to be that successful that you want to be.
Well, Andrei, you hit at least three important things. One thing is represented by the patients and how we get the patients. And right now we have three different pool of patients. Patients which already knows about their status for hepatitis C. The patients which go in different medical facilities, they are tested and diagnosed. And the patients supposed to be screened. So these are three different categories of patients which we have to keep in mind. Then is the medical field. The medical field represents a very nice stage, if I may say like this, because in this area there are two of these specialties which are dealing with those kind of patients. That means infectious disease specialist and gastroenterologist, plus minus hepatologist, because we have also a few hepatologists. And the third compartment is the infrastructure. As you mentioned previously, yes, we developed the infrastructures. We have a national registry for viral hepatitis. In this national registry, we included till now something like 50,000 patients, which has been already screened, and they're in different stage of diagnosis. And this register has different modules. The first module is screening. The second module is to establish the viremia. The third module is to establish the level of the disease. The fourth module is the therapy. And the fifth level is the follow-up of the patients. So all these steps are included in the national registry. This national registry was developed due to the fact that the Minister of Health of the Data elaborated an order through which we've been obliged to develop such facilities. So we say, okay, Minister, I like to do it. The minister just said, do it. And I've done it. So it's that simple as this. Without money from the government, pay attention, only with private finances, which is good. Private finances is good. In this very moment, the register is fully operational. What we have to do is the next step. If we put on the table a national plan of action, everybody will know exactly what they have to do. For instance, a surgeon, if a surgeon tests by chance a patient and finds the patient touched by hepatitis C, he has to access the register and enter the data of the patient. That's simple. As soon as a patient is new on the register, he's relocated to a specialist in infectious diseases or gastroenterology to be checked for viremia, and if it's positive for viremia, then it's skipped on the specialty to be diagnosed, fully diagnosed. In my opinion, if the patient is diagnosed and is seen to be F0, F1, F2, to be resent to the general practitioner, which belongs, with a medical paper, describing what the general practitioner is supposed to do with the patient and how the patient is supposed to access the medication. As soon as the medication is allocated for this category of patients, also it's seen in the register. And you see all the monitorization then. Every 2 weeks the patient is supposed to be monitorized. At week 4 we perform the viral load. The viral load is undetectable, so the prognosis is fantastic good. We do at 8 weeks if we introduce the scheme of therapy for 8 weeks of therapy, and then after 12 weeks SVR, and it's all. It's absolutely simple. Belongs to us to do this kind of things simple, but not stupid. In this very moment, we have some stupidity due to the fact that we have all these tools and do not use it fully time.
Thank you so much, Professor. I would ask our colleague Andy, because we were talking yesterday about the importance of general awareness and prevention, and you mentioned a couple of actions that were really, really effective. Of course, you were talking about the campaign on HIV, but in terms of awareness and many, many other things, these three viruses go together: Hep C, HIV, and Hep B. So basically, I would like you to share with us some important challenges that you had in terms of general awareness, and also then I would move back to France and Spain, because as you mentioned earlier, you somehow managed to have a general consensus on awareness, not only among caregivers, but also the general population, and you didn't have to fight so much in terms of convincing stakeholders that it's important to take action now. So I would go back to Andy and invite him to share with us some key elements of the general awareness and prevention that you have accomplished to do in UK, and also, now that you have an idea of the particularities of the Romanian healthcare system, maybe to try to have a comparison, an analysis of what exactly could influence from the examples that you had already in place, what exactly could be effective on the Romanian healthcare system.
Okay, could you put the slides back up for me, please? There's a couple of things I'd like, if that's possible. But in response to your first point, the campaign that we talked about in the sort of program discussions yesterday was the UK HIV initiative, which was a very hard-hitting. We're going back some time now. We're going back into the 1980s when HIV was a new disease, and everyone was scared of it, and no one was talking about it. And a very hard-hitting campaign was put out on the TV in the UK, and it was called AIDS Don't Die of Ignorance. And I'd advise you, if you're interested, to have a look at that campaign and think about it in terms of the 80s, because that's when it came out. And I'm happy to share it with you, but it's available on YouTube, and it is okay. It's a little dated now, but at the time it caused a huge stir, and it did actually raise the awareness. It took the stigma away from HIV and making it more by making it an information campaign, but a scary information campaign. It actually brought awareness out and sympathy for the sufferers, rather than have them stigmatized and cast aside and ostracized in society. So there is, I mean, the situation is slightly different with Hep C, but there is that sort of, you need to have information about it, not prejudice. You need to be bringing people out to get themselves checked, to seek help, to know their status, and if they have status, it's not a stigma, it's not a life sentence, it's something that you can get treatment for, and depending upon your status, when you need to get that treatment, because the medicines, as everyone probably has an awareness, the deal done in Spain was a very good deal, and I think it's something that Romania might be able to copy. I did the number crunching from our 214 at a price of 20,000 per course, and you suddenly get yourself close to 5 billion. which is unaffordable even in a relatively prosperous country like the UK, and the same applies to other countries. It's not affordable at current prices to treat the population as a whole. When should prices change, then the numbers that you can afford to treat will increase. The deal done in Spain is a very good deal, and that's enabling them to treat their population very effectively. The reason I put the slides back up, see if I can get the plot. Is that the one I was after? That's the one I was after. So that's the deaths, and you can see they actually start to go down. It's achievable in a very short space of time. And you would anticipate that the more people you treat, the more that line starts to go down. It's a slow process because the amount of people we're treating is relatively small at the moment. The more people you treat, the more chances you've got to get the mortality going down. I'm not sure I've answered your question, but I've probably added a bit more to the mix, I hope. So with that, I will close and pass it on to my colleagues from France and Spain. Thank you. Oh, sorry, thank you for inviting me as well. I forgot to say it at the beginning.
Thank you, Andy.
Now, in terms of awareness, I think we had many examples since a few years. The first important example was related to the HIV infections. And obviously, hepatitis C is linked to that. In order to work, such campaign should convene a very simple message. But not only be simple in the message, but it should be personal and emotional. It must strike the target in a way that then the following step is asking the doctor and then be taken in charge by the health system. And there are many ways to be emotional, to be personal, in the way that this disease is developing. But obviously, this is a contagious disease. So it's not only the fact that someone bearing the disease is at risk of developing consequences, but it's also for the case of family. We've seen this morning very interesting figures concerning the odds ratio or the relative risk for the family members, and so the higher risk for the next of kin and people we care. This is the first element. The second element is, so it's the risk. The second element, which must be taken into account, I think, for such campaign, is the potential loss of opportunity at both individual and collective level. Because it has been explained earlier, knowing that even if you are stage F0, which means no fibrosis, no symptoms, just perhaps some symptoms appeared at the acute phase of the disease, but then no symptom, just some viruses multiplying in some cells in the liver. But that represents already a risk for the patient. And then to send a message saying that the earlier the disease is detected, better are the chances to not develop complications and to be fully cured, as you said. Because now we are in a specific situation, which is quite recent, but a specific situation where we have efficient treatments to propose in order to eradicate in one individual. So that is also a message to convene. So to give the opportunity to avoid a situation of loss of opportunity to be cured, to avoid the risk to be contagious for the others, and at the community level, that has also an important impact. We know that for individuals, ourselves included, this is a message with less impact because it's indirect. It's not because we don't care about or collectivity, but it's not as important as something personal or touching the very close environment. So I would say these kind of characteristics should be bear in mind when building an awareness campaign. Please, Professor.
I'm wondering why we discuss so much about medication. Because this medication is the single modality to prevent the spread of the virus. We do not have a vaccine against hepatitis virus. So if we don't have the vaccine, we have to use the medication as a preventive tool. If we make a patient healthy, the patients will not transmit anymore and the epidemics will go down. If we don't do this right now, when we are in a good position, we have infrastructure, we have the know-how, we know exactly what we have to deal with the patients and so on. If we don't act now, we lose a very important time in history.
You know, it's very true. I cannot agree more than what you said. And but today, but it's doubtful that we will have, at least in short term, a vaccine, because the virus has such characteristics that it's difficult to develop a vaccine. But if we imagine a day where we will have a vaccine available for this virus, then all the questions we have will probably become invalid.
Thank you so much. Thank you so much. I would like to move over to Spain, because, I mean, Spain in terms of health policies has always been very creative. For instance, Spain is one of the countries in Europe that has the largest numbers of transplants, and it's still, of course, there are several factors that contribute together, but still Spain managed to, in several areas, managed to have efficiency, to prove successful measures, and all this given also some local particularities that made the test very, very difficult. So I would also like us to go over a bit how you accomplished to have good results in terms of general awareness of the situation, given the fact that also you might have some other important aspects that in Romania are not present, for instance, immigration, for instance, some other kind of population dynamics, given the special and different budgetary construction. So it's a different system, but the results were equally successful.
In this case, a long time ago was in Spain a specific government funding campaign, but in this case I wanted to focus in what the role of the NGOs. For example, NGOs, especially Red Cross and some other NGOs, have a special role in Spain, for example, with, let me say, sexual worker. So they go to speak with them, they give, let me say, condom for free or so on, in order to explain how important is not to transmit the disease. So the first one is government involvement, but also NGOs, patient associations, and so on. And the final idea, I totally agree. Probably if we give the medicine, we can cure, so this is the best way to prevent transmission. But if we don't make awareness about how the disease has been transmitted, probably the people that have been cured can get the disease again. So cure by themselves is not enough. The good idea is to explain people how to stop transmission of the disease. So, and of course, again, as a health economist, we know that all the public health issue, prevention is the most efficient way. In Romania, you have here the same problem that we have in Spain, or with the budget is limited, so we have the opportunity cost, so if we spend so much money here, we cannot spend here. So if we have to allocate resources, of course, a public health campaign is the best.
Thank you so much, Jaime. So far we've been looking at different aspects in terms of awareness, in terms of prevention, and as you mentioned, the NGOs and the private sector should have and has an important role to play in terms of prevention and awareness. But one of the mistakes that healthcare systems do often is, given the fact that most of the healthcare system have several NGOs that are really active and they work a lot with the local authorities, with the central authorities, they tend to, public authorities in terms of healthcare, they tend to decline their responsibility in terms of prevention and general awareness. So I strongly believe that we should exactly see which are who's who and who has eventually the responsibility of making sure that patients have access to treatment, to information, to prevention, and given also the fact that all of our countries have need to take into consideration the 2011 European Union directive that says that, okay, you have this cross-border right to access treatment that is not available or not available on time in a certain country. So from that point of view, speaking also of the whole circle of action and segmentation in terms of awareness, prevention, clinical management, and follow-up, I think at the end of the day it's important to discuss also about the regulatory behind all those processes, because this is the dimension that sets the responsibility and accountability for the actions that are taking place into the system. So I would go back a bit and try to analyze, because I strongly believe that one of the issues that we have in the Romanian healthcare system is related to the lack of proactivity in terms of general aspects of the disease. So in terms of prevention, for instance, we really need to develop and to improve our collaboration with the general practitioners, with eventually all the caregivers that come in contact with patients, and it's for somebody working in the healthcare system, it's easy to recognize a patient that has a high risk. So eventually it's constructive both for the caregivers, for the system, and then also for the patient to try to bring the disease to a diagnostic as soon as possible. So I would come back to Professor Străinu Cercel to discuss a bit about the regulatory issues that we're still struggling to solve, and because for instance, in terms of prevention, we don't really have any stimulating measures for the caregivers to have a proactive, to address this issue proactively. So,
well, Andre, in this field we have the local health authorities who are supposed to be directly involved in this process, because this belongs to them, local health authority. It's exactly what they have to do. Unfortunately, the number of staff in this kind of facilities diminished considerably due to the lot of things that we know very well, salaries, blah, blah, blah. We have to redesign these facilities and populate with specialists and then put them to work directly with the media. So we have local health authority, we have media, and they have to spread the message constantly. Yeah? And this message is supposed to be repeated. As Andrew mentioned, late in the 90s with HIV, with the message and so on, it's exactly what we have to do again and again and again. Fortunately, we know exactly right now how this virus are spread. We know exactly the modality and the way of transmission. We have to hit this way of transmission, but to emphasize all the time on the media, this is the modality of transmission, this is the modality of transmission, this is the modality of transmission. Don't do this, don't do this, don't do this, don't do piercing, don't do tattoo, don't use syringes which you know the origin. Pay attention where you go in the health facility and so on. If we don't do this on the regular basis, the chance to make prevention in the real terms diminish considerably. And then the place will be took by the medication, which is totally unfair. Yeah? So when we start this action plan, we have to start in 3 different ways. Prevention at messages, yeah? Therapy to decrease the propagation which is supposed to transmit the virus, yeah? And of course, the education for those who are supposed to do this kind of things.
I totally agree with you, and I strongly believe that, as I said at the beginning, we need to. It's a problem that involves all of us, and we should act together, because it's no longer a really limited issue that takes place somewhere, I don't know, far away from us. And no, speaking of prevalence, we are probably around, I don't know, close to 50 people in the room, so probably, statistically speaking, 1.5 of us are possible of having this terrible disease. So from this point of view, I'm saying that it's important to sustain every public measure, every...
Do you intend to launch a campaign of testing right now?
We're all going to be tested.
So getting back to the regulatory issue, I would ask Andy to provide us with some tips and tricks that countries in Europe have figured out in order to help local authorities in terms of involving them into this joint action, national approach of taking care and analyzing the hep C.
Far be it from me to suggest that you need a whole bunch more quangos, but and bodies. But in a way, some of them help. And you know, the point I was trying to illustrate with those slides that were produced by Public Health England. Public Health England is a body that sits within, but also overarching many of the services that are provided in the healthcare system. And its aim is to improve public health. So from that point of view, this initiative would fall squarely in the domain of a body just like that. So its aim is to improve public health and to have observatories that looks at the way treatment is responded to. So look at the national statistics and performance. It integrates those registries, and it has that overarching involvement in both identifying what the issues are, making advertising campaigns to improve people's health, and then looking at the performance of those initiatives as we've seen in that report. So whilst cause and effect isn't always there, the data they put forward is illustrative of the effect of various campaigns, whether it's rooted in the NHS, whether it's rooted in other parts of the care system. In terms of NGOs, the NGOs relevant to the hep C issue in the UK are mostly around those that support people who, I think we've got the video. Have we got sound? Sorry, we mentioned the video. I managed, while I was sitting here, I was downloading it onto my phone. If we can get sound, this is the video we were talking about. Now that went out in primetime TV, and it was a shocker. Everyone was sort of talking about AIDS in a sort of sotto voce way, and all of a sudden it was right in your face. And it had an effect. It stopped the stigmatism, and it enabled people to go and seek help, and it changed the course of AIDS in many respects. It was a part of the sort of enlightening movement that happened in the 80s. So it was iconic, and I know it looks a bit tame now, but you've got to bear in mind that's probably 30 odd years old. So at the time it was quite impressive. So apologies for bringing you a fairly naff video, but in the context of where it was. Anyway, back to NGOs. The NGOs in the UK are really about sort of supporting people who inject drugs, making sure they've got the access to safe places to inject, rather than doing it on the streets. They've got sterile needles, syringes to avoid sharing and spreading diseases, not just hep C but others. In terms of quality standards, there's the Care Quality Commission. There's that august body called NICE that sets out guidelines for how treatment should be offered. So in terms of the rights to therapy, that's enshrined in a sort of bill of rights that you have with our NHS. So you do have those rights to service, and if you don't get them, and there's been a lot of health tourism from the UK, getting operations in other parts of Europe and getting access to other facilities in other parts of Europe. And that's paid for from the taxpayers' contribution to the NHS. So those elements are in, they are, some of them are in primary law, in primary statutes, some of them are in secondary legislation that feeds out of those. But they fundamentally put people, they give public bodies responsibility for promoting health and overseeing the implementation of health and the quality of that healthcare that sits within it. And that's reported nationally to government, to MPs in Parliament, and there's a fairly venomous press that will pick up on things that go wrong within the healthcare system, which acts as a sort of a further inspection body. So if things do go wrong, it gets exposed, it goes to the courts, it gets investigated, and blame is sometimes apportioned, but the learning is the most important thing. So at many levels, there are systems that work. How much of them I would wish upon the Romanian people is a different matter. The bits that work, the bits that actually improve the services would be good. I think many of the system approaches are similar. There may be gaps in the way those are joined up in Romania, and if this initiative helps join them up and make them work more efficiently, then I think we'll have done some good work here. So thank you, and I'll pass you over to my colleagues from Spain and France to give their take on it.
I would also like to add, to see, since we've heard of the role of NICE in terms of coordinating and making people, stakeholders working more efficiently together, I would like also to go over to France and to see the role of the Autorité de Santé and to see what exactly, how exactly improve a better collaboration. Because in terms of health technology assessment, this is one independent body that we're still missing in Romania. Having an independent body that has the capabilities of gathering, has the human resources of being able of embracing really big, complex public health issues like this one that we have today on the table, the Hep C. So I would like to hear more about the role of the Autorité de Santé, the role that it played in the process of getting the control over the Hep C situation in France.
Well, you've asked the question of the situation of the regulatory authorities in general. And that situation is not easy at the level of the Ministry of Health, because the Ministry of Health, so the executive branch, which is headed by obviously the Ministry of Health, is the target of many different constraints. At the heads you have politicians. They have their own program, which has been presented before they were elected. Then you have a lot of interested parties with many different objectives, from health professionals, civil society, NGOs, industry, etc. But in the field of public health, we have to approach the questions in a scientific way. So this is where the different bodies or agencies around the Ministry of Health are or could be useful. And the HS, which is the Health Technology Assessment Agency in France, where the HS can intervene. And concerning this specific subject of Hep C, there are in particular two commissions which are of interest. Because at the opposite of the UK system, where NICE is dealing with global health economics evaluation, there are two steps, or two parallel steps. You have one commission which is called the Transparency Commission, which in fact evaluates the clinical data available after the marketing authorization, and they give a score of medical added value. So it's not for marketing, it's just to say, compared with what is available, this is something equivalent to what is available, or this is a progress. So it goes from 5 equivalent to 1. It's best. You have an important result in terms of mortality in a highly with a disease with a high level of mortality. But in parallel, there is another commission, and this is not the same kind of competencies, which is dealing with health economics, and so dealing with cost efficiency, budget impact, and so these two technical bodies are giving the results to the Ministry of Health, where in particular the decisions will be taken in particular on medicines, concerning the reimbursement of the medicines and the cost of medicines. So again, we should be evidence-based medicine. This should be based on science. But situations are sometimes very difficult because even in France, there is a cost containment logic. We do not have. We spent already around 11, 12, according to the latest statistic, % of GDP in health services in general, which is quite high. And we have a C issue, but not only this one. One of the most costly issues is related to the new anti-cancer products, covering a lot of different situations with the development of a lot of new products related to the progress in molecular biology and precision medicine. So there, after the evaluation by the HS, which is a technical body, a scientific body, then the decision has to be taken at the level of the Ministry of Health. And there are many elements to take into account, science, and compromise, where in the ideal situation for Hep C, you would treat everybody, but that was not possible in France. And this is the reason why initially priority was given to treat F3 and F4 patients, because in terms of life expectancy, horizon of complications, that was the priority. And on that basis, there was a negotiation with especially the companies producing the products to find an agreement. So, by the way, for this specific product, specific regulatory procedures were put in place to cap the cost. So this is the way it's working in France. So as everywhere, evidence-based medicine, the connection of the scientific evaluation from the decision, and decision for which, depending on the conditions, in particular economical conditions and budgets available, choice on the population to prioritize in terms of treatment. So initially it was F3, F4, and since this month, it has been said, after opinion of the scientific opinion of the HS, it has been, the message has been delivered by the ministry that all patients will be treated, even at F0. But I suspect, I'm not in the process, but I suspect because it's at the level of Ministry of Health, I'm working on the scientific commission in HA's side. I suspect that contacts will be renewed with the companies, particularly concerning the medicine products, to negotiate the price and find a solution to contain the costs of these products.
Thank you so much. Thank you so much. I would move off. I would move on to Spain to have a look at the intersection of health economics, regulatory process, and of course starting with science and evidence-based medicine. So we should start on with if it's proven scientifically that something works, then we need to pass it over a broader analysis, and we should eventually eventually we need to have some clear image of a couple of options available at that specific time. So maybe this is one of the issues that we're still struggling to solve, getting a comprehensive analysis locally. But I would move a bit further, because many countries have different problems, and they're at the different stages of accessing the right treatment and the curative treatment. But we were talking before about joint action within the European Union in terms of procurement, in terms of supply, in terms of offering access to better access for patients to the treatment, regardless of the states or of the nation and the local particularities. Because, for instance, if you're speaking about a small country with a limited budget, of course, Romania is the seventh biggest country in Europe in terms of population, but if you're talking about smaller countries that might be richer, of course, but if we're talking about smaller countries or even Romania or Bulgaria, we might struggle in accessing a correct price for the treatments, for the new emerging treatments, given the fact that the science behind it tells you that this is the right treatment for the patient. This is the option that you should take. So what would you think to share with us about this?
Yeah, I think I can make 3 comments about regulation. One is very important related to what happened in Spain a few years ago, related to the financial crisis. We have to remember that Spain was a country with a universal coverage, that even illegal people, Spain is a country with a lot of immigrants, not only legal, also illegal immigrants, illegal workers. So even doesn't matter if you have an illegal contract in Spain or you are illegal. A few years ago, you have access to the healthcare system. That is a very important issue, especially in order to stop progression of the disease. A few years ago, I think in 2011, the government decided not to give any more universal coverage, so illegal people have no access to healthcare system in Spain. So I think that right now there is a new government in Spain, the same political party, but probably will be a change in the future. Probably we will have universal coverage again. That I think is the best regulation process in order to get, in order to make very good, diagnostics and prevention and so on. This is the first issue. The second issue about regulation is regulation of the price of the medicine. It was a long debate in Spain why the price of the medicine, probably is the same debate here, why the price of the medicine for hepatitis C is so expensive. Remember, if we see the label of the product in the market right now, the labels say this product is for hepatitis C. They don't say only for F3, S4, and so on. So patients in Spain say, why the Paris Medicine Agency approved a medicine for all the people with hepatitis C, and the payer is restricted only for F4 and F3? The reason is very clear. It's a reason of affordability. In this case, we are not discussing about efficiency because we are speaking about treatment that can cure people, and also you can prevent transplantation, can prevent cancer. So in this case, we are not discussing about efficiency. We are discussing about affordability. It's not only the case of Spain, it's also the case of every country around the world cannot pay the high price of the medicine. So the second debate was related to regulation of the price. So many people in Europe say, why don't have a single regulation across Europe and try to get a better price? Let me remind you that according with European legislation, pricing and reimbursement is a national competence. So countries want to regulate the price of the medicine, so they don't want. So what is the proposal for the European Commission? If we remember that in 2014 there is a new public contracting legislation in Europe, and there is a few articles related to joint procurement. So the idea is to allow countries to go together, sit down, and make 2 issues. The first one, to sit down and negotiate the price of the medicine. So, biggest means cheaper. Remember the example that I mentioned before? We are paying less in Spain because we have getting a high volume of product. So if several small countries go together, they can get a higher volume, mean lower price. A few years ago, before this European directive, the legislation was very complex. Now, if we read this public contracting directive, the legislation is very clear, so several countries can go together and make a tender. So the next semester is the Malta presidency. It would be a meeting in Malta, yes, the European presidency. It will be a meeting, and one of the topics will be related to how to implement the joint procurement in Europe. Probably one of the topics that, of course, we are thinking not only hepatitis C, we are thinking rare diseases, we are thinking in high-cost oncology treatment, but of course, hepatitis C right now is one of the hot topics to discuss about how countries can go together and make a joint procurement.
Thank you so much, Jaime, for your input. And I believe it's important to consider the wider context, because otherwise, given the fact that the population migration within the European Union, it's important to consider also the fact that there were several cases mentioned in the mass media across Europe of patients that were not able to access the curative treatment, and they were supposed to travel to Egypt or some other countries to access treatment. So I've seen cases appear almost in every country. So I would like to hear what Professor Strinu Cercel thinks about, because also we have another case in Romania. It's only I don't know, like a couple of weeks ago that a patient just won his. He sued the Romanian healthcare system, and eventually he got the decision of being reimbursed and being able to access his treatment for hep C. So this is not only a local problem, it's a European problem, that there are some patients that need the treatment as soon as possible. They still cannot get it, and they find alternative measures of procuring the treatment.
The access to therapy is a problem everywhere in the world. So every government will take the proper decision according to the money that they have in the pocket, to be able to assure as maximum as possible according to some prioritization. This is absolutely real. The fact that the patient fight for his rights and win is something absolutely normal. I don't know exactly if the patient received the medication or just the approval of the justice. It's another issue. Probably yes, probably yes. But this was a point in this image of the therapy. I think that we have to fight, we have to push to develop the action plan to be available for everybody. For instance, in the program of the insurance house in Romania right now, the medical staff has fully access to therapy, which is something that this corps succeeded to gain. It wasn't the legislation previously from 2002, but nobody arrived to give this right to the physician, to the nurse, and so on. Right now, it's printed in the insurance house perspective, and it's something interesting. I applaud this. At the same time, I like as a physician to treat everybody as soon as a patient enters in my office, to be able to treat him in the spot. Not to delay. Each delay will add something extra. We don't know exactly what, but something extra will be added. Some more fibrosis, some more necroactivity in the liver, something is there. So from this perspective, I think that our main target is to push the politicians to have very nice, let's say, bargain with the pharma industry. The price is huge, but if no, the model that Spain presented, it's a very nice model. I fully agree, and we also suggested that we have to share this kind of model, and probably if they will listen to us, they will be in the situation to do it. But you know very well, in such context, we have to modify the legislation. And when you start to modify the legislation in Romania, you have to spend something like half a year or 1 year. And the patient don't have the necessary time to wait for. So I see this in 2 steps. The first step is to finish the negotiations that we started right now, and to have a clear vision for 2017, to know exactly how many patients we may treat, and which are the magnitude of the disease that will be treated for the first. The second step, started after the 3rd of January, is to redesign the legislation, probably according to the Spain model, and to see if it's more advantageous for us. Because if I put the bulk of money here, and I say to the pharma industry, this is my money, and I have to treat 3 million, for instance, yeah? If you accept, do it. I give you the money, doesn't matter how, but if I will have 3 million to treat it, you have to give me the medication to treat them. This is by now, as we discussed. But in the other hand is the virus. The virus is not seated like this, say, hey ducks, what are you doing? Well, we are doing well, we try to kill you. Huh? Well, just wait a little bit, because I have some mutation here in my pocket, and probably next year you will not be able to treat me with this kind of medication. What that means? That means that we have to use very wisely this medication. We have to check particular patient, but from the head to the bottom. To don't give the medication just like this, like aspirin. No, we have to be very clear, we have to explain to the patient, we have to push our adherence. If they miss a pill or two, they may jeopardize the therapy if they do this in the first week of therapy. Because you know very well that in the first 3 days of therapy, the viral load goes down. If his standard therapy has some nausea, don't take the second pill, it's a mess. So we have to be very careful with this kind of medication, because otherwise we'll start another epidemic wave with another modified virus.
Yeah, I mean, we're only now starting to see also the risk and the consequences of not being careful and effective, even at the point where you have access, you have resources to treat patients at a big scale. So eventually, it's a complicated challenge, so every country has to face it eventually. So personally, I believe that we've learned a lot in this debate. I would like to open now the question and answers.
I listened to your plans, to your ideas. They seem to be very clear, very logical, and also achievable. I understood that this is the moment to take action because we have the infrastructure, we have the treatment. But I think the element that closes this circle is the human resource. My question for you is that, is it achievable to develop a national plan, a pyramid, as you mentioned, with GPs, gastroenterologists, infectious disease specialists, also taking account that Romania is confronting with a hemorrhage of medical personnel? I think in our biggest cities, like Bucharest, Cluj-Napoca, is achievable. But what about our pure regions, our lower developed regions? Thank you.
My answer directly is yes, we have this capability in this very moment, and 2016 proved it, because we've been able to treat something like 6,000 patients with this triple therapy, DAA. But you know very well that in Romania we have a system which is formed by different networks. We have a network for infectious diseases, and we have a network for gastroenterologists and hepatologists. Those two networks are governed right now by the special societies. 2 weeks ago, at the level of the societies, we discussed how to do this, the gastroenterologist and the infectionist. And we arrived at the conclusion that the models that we elaborated with the HIV in Romania throughout different regional centers located in the university sites was a very nice model, and we can replicate the situation for Hep C and Hep B. And we are in the situation to prepare a paper for the Ministry of Health in this regards, mentions that we fully agree to work as a team, infectionist and gastroenterologist, to use the national registry as an important tool to figure out where the patient is, if the patient is well monitored, is the follow-up, it's okay, and so on. And I think that in this situation, the Minister of Health would say yes, due to the fact that I have the experience of more than 30 Minister of Health in the last 20, only 20. Well, my vision, it's your vision, you know. And each time when I discuss, doesn't matter the Minister of Health, doesn't matter the party, they agree that we have to do something. And I may give you some example. I introduced in Romania the viral load, initially for the HIV, then I switched to hepatitis C and hepatitis B, as infectionist, not as gastroenterologist. I introduced the non-invasive test. I discussed with my colleagues in gastroenterology, let's forget it about liver biopsy. Just use non-invasive test. They asked me, why you do this? Because I like to sleep well during the night. After that I perform a liver puncture, I will not sleep well until I see the patient is well, no problem, no complications, and so on. You know very well, if you put a needle in a liver, some side effects may appear. Yeah? And we know very well that if I have an efficiency of 80% of this methodology, from the point of view of histology, yes, I need it. But from the point of view of the management of the patient, I don't need it. So I prefer, and I introduce this. Slowly, slowly, the gastroenterologists accept it. So all the time has been a discussion between us, a dialogue. Yeah? When you have the arguments, you discuss with intelligent people. Yeah? I presume that physicians are intelligent people for the early beginning, due to the fact that they had to spend something like 12 years on school, 6 years of faculties, another 5, 6 years in specialty. So all the time we arrive to a proper conclusion. And in this moment, we have to do and to perform another example. With this particular situation, hepatitis C, we have the possibility to reduce dramatically the incidence of hepatitis C in Romania. Let's do it.
Thank you so much, Professor. If we have any other questions from the audience, if not, I would like to thank our guests for being with us, for sharing their ideas, and hopefully this will lead to a better understanding and will take us a step forward in our actions of getting control over this terrible disease that it is Hep C. Thank you so much once again. Thank you so much.